All right, let's jump right in. Osteoarthritis. It's probably one of the most common conditions you see day in and day out in the pharmacy, right? So today we're going to break down a really practical guide to managing it, focusing on those key counseling points, the things you can say that will actually make a difference for your patients. So let's get into it. And just to set the stage here, think about this. Hip and knee OA, they're the 11th highest contributor to global disability. That's huge. We're not talking about a minor ache or pain. This is a massive factor impacting the quality of life for millions and millions of people. And guess who they're looking to for real-world advice? Yep, you. Okay, and this first point is so important. For years, we've all heard OA described as just wear and tear, right? Like an old tire just wearing out. But we know now that's not the whole story. It's an active disease process. There are real biochemical and inflammatory changes happening in the entire joint. And that right there, that's a game-changing counseling point. It helps patients shift from thinking, oh, I just have to live with this, to, okay, what can we do about this? It's about active treatment, not just acceptance. So here's our game plan. We're going to follow the clinical guidelines, a nice, logical, stepwise approach. We'll define our goals, lay the foundation with lifestyle stuff, and then get into the meds, from the simple stuff all the way up to the tricky NSAIDs and other options. All right, first up, what is osteoarthritis? Let's talk about defining the goals of therapy for your patients. When we look at the goals, they're really all about the patient's life. Yeah, we want to knock down the pain for sure, but it's so much more than that. It's about getting them moving again, restoring function, and just giving them their quality of life back. And the message we need to be sending is one of hope. With the right plan, these goals are totally within reach. Okay, let's build from the ground up. Foundation first, lifestyle interventions. Honestly, this is the essential first-line counseling opportunity for every single pharmacist. Before we even think about a pill, this is where you can have a huge impact. And let's be crystal clear, obesity is the #1 modifiable risk factor for knee OA, the absolute most important one we can do something about. And it's not just the extra weight pressing down on the joint. We now know that adipose tissue itself releases inflammatory factors that can make things worse. So that conversation about weight management, it's one of the most powerful tools you have. Even a little bit of weight loss can make a world of difference in their pain and how well they can get around. And then there's exercise. Just look at these stats. Are you kidding me? A 44% reduction in the need for total hip replacement? That is staggering. But here's the catch. So many patients are scared to move. They think they're going to make it worse. And that's where you come in. Your encouragement is everything. You can reassure them that no, actually, the right kind of exercise is proven to help. And those benefits, they stick around for months. So once we have that lifestyle foundation solid, we can start talking about meds. Let's look at starting with simple analgesics, a stepwise approach to that initial pharmacologic therapy. So here's the typical ladder we're going to climb. Step 1, we start on the skin with topicals. Step 2, we try acetaminophen. Step 3, we bring in the oral NSAIDs if we need more firepower. And step 4, we look at the other guys, the adjunctive therapies. It's all about starting safe and stepping up as needed. Okay, topical NSAIDs like diclofenac. These are a brilliant place to start, especially for knees and hands. I mean, for your patients over 75, this is actually the recommended first stop. Why? Because it barely gets into the bloodstream. That means you sidestep a ton of those scary systemic side effects, the GI, the heart, the kidney stuff. Your big counseling point here, just give them a heads up about what can happen on the skin. A little dryness or irritation where they apply it. Manage those expectations up front. All right, next up, acetaminophen. And if there's one thing to drill home with patients, it's the dose. You've got to counsel them on the risk of hidden acetaminophen. It's in everything. So they need to be detectives, checking the labels on all their OTC and prescription meds. We all know the max dose is 4 grams a day, but for our frail elderly patients or anyone with liver issues, you're going to want to pull that back to maybe 2 or 3 grams just to be safe. And now we get to the big one, navigating oral NSAID risks. Look, they work well for pain, often better than acetaminophen, but they come with some serious baggage. Your role in balancing that efficacy with cardiovascular, GI, and renal safety is, well, it's everything. This table is basically your cheat sheet. Let's break it down. For CV risk, the main idea is just don't use them in high-risk patients if you can avoid it. If you absolutely have to, low-dose naproxen is your safest bet. For GI risk, the mantra is lowest effective dose for the shortest possible time. And be extra careful with patients over 65 or those on other meds that are tough on the gut. Think about adding a PPI. And finally, kidneys. If their creatinine clearance is less than 30, it's a hard stop. And watch out for that triple whammy, an NSAID with an ACE inhibitor or an ARB plus a diuretic. That's a recipe for trouble. So let's say you have a patient with a high GI risk sitting in front of you. What's the play? Well, you've got a couple of options. For someone with moderate risk, you could go with a standard non-selective NSAID, like naproxen, but you'd pair it with a PPI for protection. But what about your highest risk patient, the one with a history of a GI bleed? For them, you're going to want the best protection you can get, which is a COX-2 inhibitor plus a PPI. All right, but what if that's still not cutting it? Let's talk about other therapeutic choices and really understand the role of adjuncts and supplements. Let's run through a few of these. Duloxetine, yeah, it can help with knee pain, but you have to mention the fall risk in older adults. It's right there on the beers list. Tramadol, maybe a tiny benefit, but you need to be blunt about the dependence risk. It's just like other opioids. And speaking of other opioids, the data just isn't there for long-term use in a way. They are an absolute last resort because of all the side effects and potential for misuse. The glucosamine and chondroitin question. You know you're going to get this one probably a few times a day. So what's the real story? Well, the official guidelines say don't recommend it. The big studies just don't show a real benefit over a sugar pill. But we all have that patient who is determined to try it. For them, you can offer some nuance. Let them know that the sulfate form of glucosamine seems a little better than the hydrochloride. And for chondroitin, the tiny bit of evidence that does exist points to it maybe helping with hand OA specifically. What about steroid shots in the joint? Yeah, they can work for a little while. They can give you a good 4 to 6 weeks of pain relief, which is awesome during a bout flare-up. But here's the but. The evidence is kind of all over the place, and there's a growing concern that getting these injections over and over again might actually speed up the joint damage long-term. So it's a classic trade-off, short-term relief versus potential long-term harm. So when you put it all together, what's the big takeaway? It's that your role as a pharmacist is so vital in this. From that very first chat about exercise and weight loss, to doing that careful risk assessment for NSAIDs, all the way to guiding them through the maze of supplements, you are at the center of this. You're the one who can really optimize their therapy and help them get their life back. So I'll leave you with this thought to take back to the pharmacy with you. Just think about your patient list for today. Who's on that list that could really benefit from a fresh conversation about their OA therapy? Is there someone on a high-dose NSAID without any stomach protection? Or someone who's told you they've stopped moving because they're afraid of the pain? Go find that patient and start a new conversation.